Hello, Ji, Assalamualaikum, everybody. So I think we can begin the session. So I'm just going to start by introducing myself. My name is Michelle Gyani, and I work as a manager for Gallup Pakistan's public health program. And today we are joined by Dr. Saeed for our series, which is Let's Talk Public Health. And this is a series where we bring professionals who are working in the public health space to talk about pertinent issues with regards to public health in Pakistan and beyond. So, Dr. Saeed has more than 10 years of experience working in the public health sector, and he's worked with government departments and with other international organizations like WHO and CDC. So, and today we will be talking about international health regulations and the implications for what that means for Pakistan. So, Dr. Saeed, thank you so much for joining, and I would like to hand it over to you.
Thank you very much, Michelle, and hello, everyone. Today, I'm going to talk about international health regulation, as Michelle already introduced. Just before going into the topic and its significance, what it entails for Pakistan, I would like to introduce you to the holistic purpose of this whole discussion which we are going to have today. In fact, world needed a shift in the paradigm, shift in the you can say the way the public health was being dealt. So there was a need to change the system. There was a need to change why public health should be modernized and revamped. That was the purpose. And what actually changed the very basic question of how public health works? ये चीज कहाँ से arise हुई कि public health को change होना चाहिए, the way it is working is outdated and now new things need to be inducted. Dear participants, the beginning of this whole story arose from a pandemic which started in 2002. That was known as SARS, Severe Acute Respiratory Syndrome. That was not pandemic in true sense. That should be known as epidemic rather. Because pandemic involved the whole of the world, as we saw in COVID-19, while epidemic actually stays limited to one or more continents. It doesn't spread truly to whole of the world. So that was an epidemic, which was SARS, Severe Acute Respiratory Syndrome. That was a trailer which COVID-19 showed to us, basically. So it was a prelude to that, you can say. And Severe Acute Respiratory Syndrome arose in 2002. It started from Far East countries, China, Hong Kong, and it spread to most of the countries of Asia. And it was a respiratory virus which affected the lungs and the respiratory system, just like the similar way COVID-19 affected whole of the world, but it was slightly softer version, you can say. And world was basically deeply moved by the outbreak of SARS. SARS actually highlighted the need of public health revamping and how public health actually works and how these health systems basically work all around the world. So वो एक पहला event था, वो एक पहली ऐसा episode था which actually made us to introspect, made us to look around the way we are working. So उसमें actually हुआ क्या था ऐसा? Because the trade and the movement of the people around the world was very fast. I mean, people were moving around the world because world has revolutionized in terms of logistics and the mobility. So virus was actually spreading at the same pace as people were moving from one continent of the world to another. So world sat together under the leadership of UN, United Nations, where all the countries are represented. So what actually happened at UN session of General Assembly, there is a World Health Assembly, WHA, which works under WHO, basically World Health Organization. So there was an assembly of the whole of the countries of the world under UN. In that session, they decided that public health needs to be revamped, the health system need to be changed, and the approach towards health system needs to be changed. So that agreement actually came into writing in a form which is known as IHR, International Health Regulation. So, international health regulation, which we saw, that document was unveiled in 2005, and that has the marking of WHO, World Health Organization, on it. So, technically, international health regulation is a document which was signed by all the countries of the world. 194 member states of UN are at the moment. So, 194 member states signed that document, which came on the surface and now known as International Health Regulation 2005. And in that document, whole of the world has basically pledged, has promised that they will prevent, detect, and respond to public health emergencies within their own sphere, within their own domain, and they will not let the disease spill across the border into another country. So that was the whole pledge which they made. But it is not as simple as it sounds. It is very easy to say that every country will strive its best to contain the spread of disease within in its own domain, and it will not let the world to suffer from the diseases all across. Point is that in international health regulation, when I say they, it means WHO, which is a technical lead on health related matters all around the world. WHO identified 19 technical areas which need to be addressed if public health need if we want public health to be strengthened enough to prevent the diseases at the early stage. So 19 technical areas need to be addressed. That was the crux of that whole document. And what are those 19 technical areas? Just for your interest, I will name few of them. For example, legislation, financing, and coordination should be strengthened. There was another component which says that disease surveillance should be strengthened. There was another component which says that national laboratory system needs to be strengthened. There was another component which says that points of entry needs to be strengthened. When we say points of entry, it means airports and the ground crossings from where people and trade actually occurs. So points of entry is very important for us from health point of view. So point of entry need to be strengthened. That was another thing. Then AMR, antimicrobial resistance, that was another area which was identified and need to be strengthened. Then another area which is public health emergency management and response, that was another area. Then, of course, there were certain other areas which are not directly related to that, but again, for example, radiation safety and threat from the nuclear weapons and all that, because that come under the larger domain of the public health threats. But for now, we are limiting ourselves to epidemic diseases. So under those 19 technical areas, most of them were directly related to containment of spread of diseases, for example, SARS or similar diseases. So that was the roadmap or the blueprint which was provided by WHO to all the member states. And it was decided that all member states will actually work together, and they will build the capacity, and they will actually strengthen their health systems by complying with all those 19 technical areas. But again, the story is not that simple as it sounds so far. In those 19 technical areas, there were 56 indicators in total. So 19 technical areas in total and 56 indicators. So it was quite an objective document, very beautifully carved out and very beautifully written. And it actually encompassed and it actually covered whole of the area, you can say, which can directly or indirectly affect the health. So in those 19 technical areas, they devised 56 indicators that such and such indicator will tell whether that indicator has been met or not. So against technical areas, they developed 56 indicators. And against those 56 indicators, they actually set a deadline as well, that each country is required to meet that deadline of improving those indicators in a certain set of frame of time, in a certain period of time. So moving further, when they developed that and when they actually took the first step towards reformation of the public health, Pakistan, fortunately, was one of the country in South Asia, rather whole of the Asia, I must say, who volunteered for joint external evaluation. What is JEE, Joint External Evaluation? Joint External Evaluation is a mechanism in which a country asks the experts from WHO and other member states that come in my country, assess my health system, and tell me where the gaps are. So joint external evaluation, as the name indicates, a joint evaluation. I mean, the national experts of that country also sit together, as well as the international experts come together. So they jointly assess the health system's capacity and all that. So what they did, Pakistan volunteered that the WHO and the external partners can come and assess the health systems of Pakistan. So in 2016, Pakistan's joint external evaluation was completed and the report was published, and it is again available on WHO website as well. I will recommend to go through the findings of that. One of the major finding was that Pakistan, except two or three technical areas, was below par in all other technical areas, which was quite obvious as well. So simply speaking, Pakistan health system is not strong enough to contain any epidemic for that matter. That was the finding of that very voluminous report, which was published in 2016. So what next? We all know that our health systems are not good enough, and that report also documented that in a quantitative fashion, that we all know. But what next? Then they decided that since health systems of Pakistan are not good enough, so let's now work for the betterment, work for the improvement of the health system. So for the betterment of the health system, for the action, what they did, they introduced a mechanism which is known as IDSR, Integrated Disease Surveillance and Response. Integrated Disease Surveillance and Response is a strategy. Again, this is a WHO-led strategy, which is already implemented successfully in most of the African countries. And what it says that health is not the problem of health department only. Health is a problem of everyone, be it health department, be it allied departments, be it private sector, be it civil society. So health is a problem of everyone. So everyone has to sit together in an integrated fashion. They have to work together for the disease surveillance and response. So that is why they devised a strategy, a program, you can say, which is known as IDSR, Integrated Disease Surveillance and Response, which says that disease surveillance, so as you might be aware, surveillance means detection of disease. So diseases will be detected in an integrated fashion and they will be responded to in an integrated fashion. So that was the whole spirit of that strategy of IDSR, that not only the detection will be done in a coordinated fashion, but response will also be done in a coordinated fashion. So IDSR was implemented in Pakistan in 2018. And till here, I will like to remind you that we started our journey from 2005. And so we developed IHR, and we developed that in the wake of 2002 outbreak of SARS. So still, we were lagging behind in terms of implementation. Not only we, even the whole world, but Pakistan was lagging far behind as compared to the other countries, because other countries actually strengthened their health systems in a much swift way as compared to Pakistan. But Pakistan, till 2016, we were identifying the causes of our problem. And in 2018, we were taking the first baby step towards strengthening our health system. So 2018 was the year in which we started implementing IDSR in compliance of IHR, by the way. And by the end of 2019, we were struck with COVID-19. So that was a disaster. We were actually preparing the whole system to prevent an epidemic, and then that epidemic didn't provide us the sufficient time, the luxury and the opportunity of time, and that actually overshadowed all the efforts, and it struck in late 2019. So 2020 Pakistan witnessed first case of COVID-19. So for all practical purposes, we were caught off guard by COVID-19. Had we taken the timely measures in the wake of IHR, because IHR gave us a warning sign, it gives us a bell that we should actually prepare ourselves for the future pandemic, but we unfortunately we didn't pay any heed to that. We didn't listen to that. So COVID-19 showed us the, in not only to us, but I mean to the whole world, it shows that our health system needed to be strengthened well ahead of time. Like in 2005, we should have improved ourselves. We didn't. So a result was that COVID-19 was there, and all the whole of the world actually came into the grip of COVID-19, and we saw the disaster and the miseries all around the world. People dying, a lack of oxygen, lack of everything. PPE were not available to the doctors. So this was actually the flaws which were exposed of the health system. And when I say health system, it was not only the health system, it was the system of that country, system of the world on which we were working, that was all exposed by COVID-19. And by the way, I should remind you again and again that these actually exposed that those 19 technical areas were not strong enough. They were not actually met well in time. That is why we had to face the misery of COVID-19. So COVID-19 actually, when it was a blessing in disguise as well, I must say. Some of you might get surprised why it was blessing in disguise. The reason being, when I say it very safely, blessing in disguise in a way that on one side definitely it played havoc with the lives and the livelihood as well. But on the other side, it actually reminded us of our responsibility to act in a coordinated fashion, to act in a responsible manner, and to strengthen our health system before it is too late. So that's what actually COVID gave us the lesson. So it's a separate story how much we learned the lesson. I will shed some light on that as well. I mean, how well prepared now we are, which the topic is of the discussion today. But again, COVID-19 actually highlighted those areas which we already knew about in 2016 Joint External Evaluation Report. So in COVID-19, we actually worked in very, on war footing. We started working and we developed most of the systems as well. I must say, health system was highlighted, and in those 19 technical areas, we worked a lot during COVID-19. For example, I'll share some evidence-based examples. Pakistan has 19 points of entry in total. So we have total 19 points of entry. When I say point of entry, it means airports, your seaports, and the ground crossing. So there are 19 airports, seaports, and ground crossing in Pakistan, from where people can move in other parts of the world, or vice versa, people can come from other part of the world in Pakistan. So those 19 points of entries were strengthened enough during COVID-19 times, because you might be aware that disease cannot spread until unless a person crosses the boundary of that country. So for us, those points of entry are very important, right? So before that, points of entry were in a very bad shape. I mean, there were no screening mechanism. Some of you might have traveled domestically or internationally during COVID or after COVID-19 time. You might have seen, even the media, you might have seen, if you have not traveled, by the way, you might have seen that thermal scanners are there. Even the screening of the passengers is going on. Biodata is being gathered in the form of the mobile application. You have to enter your biodata, everything. Park Pass app we actually developed during those times. So all these measures were actually part of those IHR mandated actions which Pakistan pledged in 2005, which were highlighted in 2016, and which were exposed in 2020 in Pakistan. So this was the sequence of the same thing which we are talking about all the time. So COVID did nothing. It actually exposed us. It actually showed us the mirror where we stand and where we should go actually. But good sign is that the upside of the COVID-19 is that we started working very seriously because it was a matter of life and death for us and for the whole world as well. And so not only we improved COVID, the points of entry in Pakistan, we also developed our national lab system also. Previously, we only had a national reference lab, which is situated at National Institute of Health, Islamabad, and that was the only lab we had. But in COVID-19, we expanded the lab network in provinces as well. Now we have 8 provincial public health reference labs all across the country, one in each provincial capital and one in national level, and few others in other parts of the country. And that is not the end of the story. In national lab system, we increased the capacity in the mobile lab as well. For example, you might be aware of Taftan issue in Pakistan from where COVID-19 entered from the Pak-Iran border, Taftan area. So we sent a mobile testing lab, which was equipped with testing the PCR facility it had. So COVID-19 testing actually we started through a mobile van as well, which was a huge development. It was unprecedented and even it was never thought of. But again, COVID-19 actually helped us to move together with that thing as well. So national reference lab system, we call it NRL, National Reference Lab System, that was strengthened during that period of time. Then I talk about surveillance. Surveillance means detection of the diseases. That was also, I can say, very much improved during COVID-19 time. And I must share with great pride that Pakistan, out of 156 districts of Pakistan, IDSR, Integrated Disease Surveillance Response, has been implemented in 48 districts. So 1/3 districts of whole of Pakistan have been enrolled in IDSR, which is need of the hour, which is the best way to detect the disease in real time, and not only detect the disease, to respond to disease as well. So IDSR is a strategy. It's a mechanism which actually helps us to act in a timely fashion. So that's we have implemented in 48 districts. So data is being reported on 33 priority diseases, and of course we are still far behind the satisfactory level. Data quality might be an issue. Whole of the districts are not covered yet. So yeah, I understand that. So, but again, we have taken the first step towards that a long journey, and that was really required. Similarly, we have also worked on the workforce development and capacity building. We actually trained the doctors and the paramedical staff and the frontline health workers. So all that. Risk communication is another area which I forgot to mention earlier. That is another area which was highlighted, and it's one of the technical areas as well, by the way. So risk communication and community engagement was another area which was strongly worked upon during COVID-19 time, and we actually worked on that, and successfully we were able to manage that. And you might have talked, you might have listened to people talking about that Pakistan was comparatively far better the other countries in the region as well as globally. What was the reason and all that? I must assure you that although we woke up a bit late, but we really worked in a very coordinated fashion, and the example is in front of you that we established NCOC, National Command and Operation Center, because in health, I must tell you very important thing over here. In health, as I mentioned earlier, health is not only the problem of health department. It can only be effectively managed until unless whole of the community, whole of the departments, whole of the government machinery works in a coordinated fashion. And what NCOC did, NCOC actually brought all the stakeholders on one table. There was a uniformity of the command. There was a unity of the command in that NCOC. One decision was taken on the basis of data and everything, and that decision was implemented. Schools has to be closed. That was a unanimous decision which went all across the country. country. Marriage halls have to be closed. That was a decision which again was passed unanimously. So airports, flights has to be curtailed or closed. Again, that decision. So it was a nerve center. It was a decision-making entity, NCOC, which took the decisions, which passed the decisions to the country, and that was the only effective way to manage the epidemic. So one of the good lessons learned of that whole exercise of COVID-19 in Pakistan was that unity of command is a must to curtail those diseases like epidemics in future as well. So that was a very clear lesson which we got from COVID-19. So these were some upsides and downsides of COVID-19. Now, I will come directly towards that where we stand today and where we foresee ourselves in the wake of any future epidemic or pandemic. As far as Pakistan's current capacities to curtail or to contain or to respond to any public health threat or epidemic is concerned, let me share another interesting thing with you that Pakistan's another in 2016 first joint external evaluation was done of Pakistan. I mean, if you came to know what are the strengths and weaknesses of the system, and currently we are passing through the second JEE of Pakistan. Pakistan's second joint external evaluation is being conducted currently. Internal evaluation has been conducted, and the external mission is due to arrive in Pakistan by the end of this month. So Pakistan's second external evaluation will be conducted by the external mission, which is a norm actually, and that mission will complete its evaluation by next month, and the report will be published, and that report will show where we stand now. So that report will be that is much awaited for us as public health professionals, and not only for us but for the country's political and administrative leadership as well, because that will tell us in a quantitative fashion, in a verifiable and authentic fashion, what capacities Pakistan have in terms of detecting, preventing, and responding to diseases. Because JEE is an authentic way to ascertain, to determine your capacities in the health system. In 2016, I mentioned that we were below par, but during COVID-19, we actually tried to catch up that train, and I'm sure we have caught that train to too larger extent. But now we are passing through the other phase of joint external evaluation. People from abroad will be coming, the external partner, the experts will be coming, and they will be evaluating our performance. So we are anxiously waiting for that, and through Gallup, I will be sharing some other time the findings of the report when that will be out, and so that will be very interesting for us, that where we stand now and in which areas we still need improvement and all that. So that is the one important news I wanted to share with you, that joint external evaluation report is due to arrive. But having said that, I can tell you one more thing. Where we stand about the future pandemic, like God forbid, if another calamity hits us in coming future, where we stand. I'm not being too ambitious, but I must tell you that during COVID-19, we have learned a lot, number one, and we are comparatively far better prepared to contain any epidemic which can strike us in future. When I say that, I have certain reasons to say that. Number one, lessons learned of COVID-19 still stay with us. NCOC is still there. You might have seen that during COVID-19, during recent super floods in Pakistan, they again activated NCOC, right? So because the nature of emergency was such that again coordinated approach was required, so they again activated NCOC, and that is how Pakistan was effectively managing the health-related issues of recent floods in Pakistan. So that is again one thing which I can safely, that if another calamity hits Pakistan or world, God forbid for that matter, we would be able to activate again NCOC system, because now that is something which has ingrained in our memory, in the institutional memory. So we will be far better prepared to contain any such emergency, number one. Number two is that the international support of donors and partners and the collaboration which we establish and strengthen during COVID-19 time, that is an asset which will stay with us and which we will actually utilize and capitalize upon in future, that I can say safely. So we are well prepared comparatively. Again, I'm not saying that we are 100% prepared, but again, we are comparatively very well prepared to contain any future epidemic, because of the fact that the partnership and the networking with international donors and partners, the expertise and the skills and the support which we have got from them during COVID-19 time, that has actually stayed with us, and it will continue in the longer run as well, to make us to enable us to contain any epidemic in future. That was the second ground on which I can say we are comparatively better off as compared to before. Thirdly, I must say that the inputs which we have received during COVID-19 time. When I say input means points of entry were strengthened, national lab system was improved, health capacity was improved, IDSR has been launched. So these are the inputs which we have received during COVID-19 time. These inputs actually work for health system strengthening. We are all aware of that. So health system strengthening is underway, is under transformation in Pakistan. So we are very much helpful that in future these inputs will serve us in a better way to contain any public health threat in future. These three reasons, on the basis of these three reasons, I can say that we are better off. But again, there are certain challenges which we should overcome in order to get better off in terms of our preparedness. One challenge is institutionalization of the efforts and the lessons learned. That is the need of the hour. Unfortunately, what we do, what we have done even in the past, that a calamity comes, we are very well prepared, agile, we do everything, we run from pillar to post to get the things done. That is the national character we have developed. That is the perfect thing. But once the calamity is gone, lessons are forgotten, it vanishes into the air, and we are not actually institutionalizing those efforts in a coordinated fashion. If we institutionalize those efforts, then we can say that we are very well prepared. I will give you an example of what I mean to say institutionalization. For example, we need to develop a document which can say that this is the National Emergency Response Framework. We do not have any National Emergency Response Framework so far. And during COVID-19 time, we developed a very particular document, which was COVID-19 framework, but that does not cover all the public health threats or emergencies and all that. So what we need to do is, NDMA has that, National Disaster Management Authority has one such document, but unfortunately that misses out on the health component. So what we need to do is, we need to develop a national health emergency framework, a response framework, which can work well for all the current and future epidemics for the country, be it monkeypox, be it any other XYZ coming in future. So that framework is required for us. When we say framework, we should also keep in mind that Pakistan currently, the health system of Pakistan is a devolved one. We have devolved the health system to the provinces, and provinces are empowered and authorized to make their own health policies. But for that matter, the role of the National Ministry of Health, which is known as Ministry of National Health Services Regulation and Coordination, that is of paramount importance. The reason being, it should coordinate those efforts and should try to develop a single national framework. It might be customized as per need of the province. That is, there is no harm in that. But point is that certain principles should be in common for all the one, and that framework should be in place, and that framework should also include the EOC as well. That is another important component, which is known as Emergency Operations Centers. For us, it is a mini NCOC, which is available on every province and all that. So EOC should be operational, should be functionalized, and should be documented, and institutionally it should be established. So that is something which is really required for us. So this is challenge number one, that institutionalization of the lessons learned and the framework should be in place. That is one challenge which need to be addressed. The other challenge is for every problem that is a challenge, I think for us, that is the lack of sufficient resources. When I say resources, it means both, like human resource and the financial resource. Unfortunately, in Pakistan, what approach, and for that matter, all low and middle income countries, I must say, they are heavily dependent upon the donor support and everything. Suppose a calamity comes, donor support flows in, and immediate requirements are met on ad hoc basis. But once the support is over, the system collapses, and system, you have to wind up the whole strategy and system, and there is no trace of anything left behind. This should not be the case anymore, right? Government, of course, I understand that, and we understand as well, that it is a responsibility of the government to sustain any health program or any intervention in the longer run. We agree to that. But point is that government should actually increase its fiscal space to allow the interventions to sustain in a longer run. So that is another thing which needs to be government's priorities, and the fiscal space needs to be enhanced so that in the longer run programs can be run. I can give you an example of the current IDSR, which I was mentioning earlier. IDSR currently, I mean, till a couple of months back, it was again donor supported, right? But fortunately, government developed its own PC1, which is government document, which says that we will own this strategy onwards. So government developed its PC1, and PC1 for ICT, I mean Islamabad, AJK, and GB has been approved, which is a good news. Means IDSR will be sustained in these three regions by the government resources. And federal government has requested the provinces to develop their own PC1s on IDSR so that they can also sustain that in the longer run. So that is, but so far, no province has come up with PC1, but they are in the stages of various stages they are at in developing that. But we are really hoping that PC1 will be developed so that government can show its commitment and support to sustain that in the longer run, which is highly required. Last couple of minutes, then I will be open to questions if you have. Another challenge which we need to be addressed is that role of leadership, be it political leadership or be it leadership in health. That is of huge importance as far as health system strengthening is concerned. Unfortunately, one government comes and it has different policies. Policies go with it. So stands true with the health leadership as well. If one leader is agile, is active, is visionary, things are at different stage. Once leader is gone, sometimes things get so. The policies and institutions, we all talk about the same mantra every time, that policies should be above the people. People should actually come under the institutions. We all know that, and we all pray for that to happen in our country as well. But this is very important that all the policies should sustain irrespective of the tenure of the government, tenure of the health leaders sitting at the helm of affairs. But point is that the sustainability always lies in the consistency of the policies. So these are three challenges, and previously I talked about three strengths which we have already achieved. If we cover these three challenges, then I am very sure that in future we will be far better off in containing any pandemic or epidemic for that matter. Thank you very much. I'll stop here, and I am open to question. And sorry if I was too fast for some of you to, describe all the events in a sequence. But again, thank you very much, and open to question. Michelle, please, over to you.
Thank you so much, Dr. Saeed. That was very, very enlightening. I think all of us have learned a lot today. So I'm just to adding off on your comments and your feedback that you've given with regards to the performance of the health sector. So again, like we have, of course, one of the things is, or one of the issues that we normally face is the lack of institutionalized and coordinated efforts. And we've generally had a more reactionary stance than as opposed to a precautionary one. So even when the epidemic or the pandemics, if they strike, they're sort of one kind of disaster, but we have other disasters that take place as well. For example, we had floods come up last year, which were also quite unfortunate for us as well. But and you have these systems which are set up, like IDSR is now being implemented, as you mentioned, in 48 districts. But again, we do somehow, the conversations that we do end up having are of multiple different authorities working in silos or in isolation. And that conversation is still very frequent. So I'm just confused, or I just want to see how, how difficult it is to actually to get everybody together and kind of bring in that coordinated effort when a disaster actually strikes, and how do you see that actually happening successfully in future? So if you can just shed light on that, that would be really great.
Yes, very well pointed out, Michelle. That is, there is no denying the fact that all the relevant stakeholders are not on one table when it comes to decision making. Even I would add to that, to your comment, that so far, health decision making and the health has been revolving either among the few government departments of the health or certain partners. That's it. I mean, and, it has to be broad based, like academia should be part of that, even civil society should be part of that. Like the some of its a glimpse of it we saw in COVID-19, that we took on board, we tried to take on board almost each and every stakeholder which was really required. But point is that in our country, there is a concept all across the world which is known as health for all and all for health concept, which says that health should serve to all, and all should actually strive together in an integrated fashion for health. I give you an example of that. For example, Pakistan is an agricultural country, we all know. If you want to, for example, if you want to install a factory of manufacturing factory of any kind in Pakistan, you are free to go. You can buy an agricultural land. You can just erect a factory over there. No one will stop you. This is not the case in developed world. They will ask you, the land you are utilizing for installing a factory, is that an agricultural land? Yes, it is. If it is agricultural land, then what will happen to the agriculture? Are you not compromising on the food security of the country at the cost of installing a factory? Why don't you install a factory at such an area which is less productive in terms of agriculture? That's the question they ask. So this is the policy they have ingrained in their system to cater to health and nutrition and everything. Similarly, they will ask you before installing, if you install a factory, what will be the compliance of the environmental standard which they'll be following and all that. So point to tell you is that taking a decision involves the health related policies since the very beginning in those countries. The reason law and legislation is very strong, very pro health, and very pertinent to that. Unfortunately, we do not have that at the moment. So again, everything starts with legislation. I think, and again, I mentioned that in 19 technical areas, legislation was number one technical area which need to be addressed. So again, thing is that legislation need to encompass, need to cover all the health related component, number one. And number two, legislation should also be there to make it mandatory that a broad-based consultation involving all the relevant stakeholders should be there. Without that, the dream of achieving health for all will never be achieved. That's my point. Is
Gigi, I think yes, of course, that makes a lot of sense. Legislation is, of course, lacking in a lot of different areas in our country. That is one of the issues that we have till date faced, unfortunately. I do want to open the floor up for questions, and if anybody does have a question, you can unmute yourself and also please introduce yourself as well when you ask a question. G, Momna, go ahead.
Thank you, Michelle. Assalamu alaikum, Dr. Saeed. Thank you so much for that very illuminating discussion. I'm Momina Junaid. I work at Gallup, Pakistan as a researcher. Um, I would like to actually pick up on the thread of your talk where you spoke about, the overall development of Pakistan, of the IDSR framework in Pakistan, and how over time, how it was developed, how it has improved, and how we've adapted it to address different challenges that we face. One of the examples you mentioned is the recent, along with the COVID-19 pandemic, is the recent flooding of last year. There had been a lot of conversation last year. Ki jo floods aaye the, they were more devastating than past floods, and so was their impact, largely because of the effects of climate change, right? So I was hoping you could contextualize IDSR implementation in the reality of climate change. So because of climate change, disasters like this are going to happen. Obviously, infectious diseases का incidence भी बढ़ जाएगा, but also climate change की वजह से NCDs का भी incidence बढ़ता है. Non-communicable diseases also have been shown to really be, the risk of those really increases with climate change. And so with this in mind, can you talk about how the IDSR framework might have to be expanded or adapted in Pakistan in order to address and non-communicable disease challenges in general, and maybe with the reality of climate change in mind?
Yes, Momina, thank you very much. Exactly, you're spot on the problem which we are suffering from. Let me share a good news, first of all, that IDSR already has the capacity to accommodate communicable, non-communicable, even mental health. So it's a broad-based strategy of responding to the diseases. By the way, till now, we are using IDSR only for infectious diseases. That is true. I mentioned about 33 priority diseases in Pakistan. They are mostly infectious diseases. The reason being, infectious diseases are, the nature is that they are sudden, they have the potential to become epidemics, so we are more concerned about that. So in IDSR, in the beginning, we are starting with the infectious disease. That is correct. But it doesn't mean system does not have the capacity. It's not like that. System does have the capacity. IDSR is a beautifully designed, updated system. It's a strategy which is, I already mentioned, it is already successfully achieving the results in most of the African countries, apart from the developed countries which adopted it way time earlier. So IDSR, number one, answer to your question, yes, it has the capacity. It can incorporate. Punjab is the province, first of its kind in Pakistan, who has shifted its IDSR on communicable diseases as well. They are reporting the data on DHIS2, which is the digital platform for IDSR. They are reporting the data on District Health Information System 2, DHIS2, for both communicable and non-communicable diseases. They have incorporated 60 plus diseases on which they are reporting the data. And the reason is that, the rationale is that it is a real-time data which is collected. So action is, again, can be generated in the real time. So it is fast, it is quick, it is actionable. So that is one thing regarding IDSR. You talked about environmental health and all that. Let me tell you another thing. We are following a concept. Again, it's a today's world concept, which is known as One Health concept. When we say One Health is a strategy, again, led by WHO and the international partners. It says that if you have to tackle the human health, you have to follow One Health strategy, which is comprised of a triangle, and that triangle has 3 angles. One angle is human health, other is environmental health, third is animal health. One Health strategy says that unless you cover all these 3 aspects which are interacting with each other, with one another simultaneously, you are not able to improve the human health. Let me be very clear over here. Ultimate aim is human health. We are all striving for improvement of human health. That is correct. But human health can never be improved unless we take into account simultaneously animal health as well as environmental health. When we do that, then yes, of course, you can dream of achieving a sustainable development goal, SDG 3 of health for all concept. But without that, you cannot do that. As far as IDSR is concerned, as I mentioned, it says that integrated disease surveillance and response. When I say integrated, it means to integrate with environment, to integrate with human, to integrate with animal health as well. We at this stage in Pakistan, we are in infancy stage of interacting and integrating with the environmental and animal health. But within human health, we are first striving because we do not have legislation so far. We are moving towards that as well. There are a lot of challenges why we are not there, because it is very easy to say you can interact, you can integrate with other sectors as well. But how you will do that? You do not have any legislative framework in your hand to do that. So I think that is the thing which needs to be done. But once that is done, system has the capacity. I'm telling you again and again, IDSR has the capacity to do that. It is beautifully designed. It can cater to all the needs which can come forward in our way. But once that is done, of course, things can be done. I hope it answers your question.
Yes, thank you so much. Just a quick follow-up. So basically so one thing I got from your discussion is NCDs aren't as much of a वो इतना burden नहीं डालती system के ऊपर जितना infectious diseases डालती हैं. That makes sense. But is there, so like in the policy sector, does climate change as a concept come into discussion or into play when we're evaluating, when the government, when the health sector is evaluating how to respond to infectious diseases and thinking about planning for the future of such disastrous events to occur?
Yes, it does. Simple and short answer is yes, it does. But again, they are still wondering both around the legislative framework, how they can bring environmental sector into the ambit of the health if they want to achieve that. In the area of smog, they have made a separate strategy. Again, health is a provincial subject, so provincial departments have made their own laws related to tackling of smog and all that. But we are talking about environment in the larger fashion. When we are talking about environment in a larger context, even environment leading to the detrimental effects on the whole environment and causing the flood-like situation, then we are still far behind. And again, we are also signatory to certain international conventions as well. So we still need to work on that to do that. But yes, they take that into account, the answer to your question, but they are still stuck up with legislative framework where things can go forward with that.
Right. Thank you so much, Dr. Saeed.
Thank you.
Ji, thank you so much. Ji, I still want to open up for our last 4 to 5 minutes. If anybody else has any questions, please do feel free to ask. Okay, I'm not sure if anybody else does. So just in our last couple of minutes, Dr. Saeed, if you could just give some closing remarks. And I think the question that I would ask you is that up from 1947 till now, do you think Pakistan, of course, and the answer would be taken with a grain of salt, whatever it is has a reason to celebrate or with regards to the performance of the health sector? So that is just my final question. And if you can just leave us with your parting thoughts on this.
Yes, I can say with a great degree of confidence that we have a lot of reasons to celebrate as far as our COVID-19 experience is concerned. At the same time, we have a lot of lessons learned in terms of challenges we are facing, and we should actually tackle them. But as far as the brighter side and optimism related side is concerned, yes, we have reasons to say that we were performing worse in the past and bad in near past, but good now and inshallah best in future.
Great. Thank you so much. Ji, thanks so much for joining us, Dr. Saeed. This was again a very good learning experience for all of us, and thank you to everybody else who also joined. And we hope to stay in touch with you. And I think we can close the session. So take
Sure.
care.
Thank you. Thank you.
Thank you. Take care. Allah Hafiz.